You're gonna go to presentation mode. There you go. Okay. Okay, take it away.
All right. Thank you everybody for being here. Good afternoon. My name is Calvin, and I work on this project with Judy. Today, we are excited to share our discrete image simulation model, which focus on emergency department within the hospital. Next slide, please. So we all know emergency department play a very important role in the hospital, but many of us have experienced or heard of long waiting time and overcrowded ER space. And that's a problem we want to explore. So which is why are the emergency room often so overwhelmed and how can we improve their operations by using the simulation model technique that we learned from this class. Next. So we think this is just a hospital operation issue, is a public health concern. For example, in 2022, the US has over 833 deaths per 100,000 people. That's a 30.8% increase compared to a decade ago. And also, like in the US, life expectancy also dropped about 8.6% of the population, and also there was a in 2021, 8.6% of people in the US have no health insurance. All of this put more pressure on the emergency department. Next slide. So to inform our work as well as the project, we look into the existing research. One notable example is Professor Nida from University of Malaysia. Which is the simulation patient flow emergency department model. Because of time constraint, I'll just quickly summarize this model, and we will explain more in our final paper. So it's a so Professor Nida came up with a simulation-based decision-making model, which purpose is to improve the patient throughout time within the emergency department. It's initially we all the hospital across the world can using this model to discover how we can speed up the process for patient move through the emergency department. And I think this study give us valuable inspiration for design our own simulation. Next, I'll hand it over to Judy.
Thank you, Calvin. So this is an overview of our ED simulation process, which we created using Cloudus. So our model simulates from a patient's arrival at the NYP Wall Canal to their discharge or the next steps in their care. So the process starts from patient's arrival at the hospital, either walk-in or from the ambulances. And then the patients will be assigned based on the severe level of their conditions, ranges from 1 to 8. For levels 1 and 2, that means the patient's condition is life-threatening. So those patients will be directly taken to see the doctors. While the other patients range from 3 to 8, they have to go through 3 processes. From the intake nurse, room assignment, and doctor's visits. Each process will have its own queue. Patient must complete them in order and remain in a single line throughout the process. After completing all the processes, patients will then be assessed to determine whether they can be discharged or require further medical care. So our model is, the goal for our model is to minimize the waiting time while maintaining the staff utilization rate. And here are our key metrics: the average total waiting time, the critical, for critical patients versus the regular patients, the average hands-off time, the total time to exit, nurse utilization rates, doctor utilization rates, and the beds utilization rate. For our simulation, we use the EMS incident data to model the patient's arrival. This data set includes all individuals who called 911 and then were transported to hospitals in New York City. However, since emergency procedures and the patient volumes can vary significantly between hospitals and regions, using the entire data set won't provide an accurate picture. So we decided to focus on specifically on one hospital. It's New York Presbyterian Wall Canal, which is a hospital we are more familiar with. In addition, even though the patient arrivals are often assumed to follow a Poisson distribution, emergent service arrivals tend to deviate from this pattern. So we actually did chi-square test for the patient arrival data and then found a p-value under 5%, leading us to reject the new hypothesis that the patient arrivals follow a Poisson distribution. Also, we analyzed a QQ plot, which revealed that several outliers here are in the eighth quantile, indicating that the high patient volumes there are high patient volumes during certain time of periods, but one. So we did further investigations. We found that those peaks typically occurs on weekdays from 7 a.m. to 3 p.m. So because our goal is to minimize patient waiting time, we choose to focus our simulation specifically on weekdays, where peak demand and potential bottlenecks are most likely to occur. So this is our all the data input that for our simulation model. For the patient arrival, we use the year of 2021 to year of 2003 data to exclude effect of COVID-19. We only use the weekday data because that during weekdays are potentially have high peak demand for patients. For the actual lambda, because our data set only includes ambulances from 911. Well, did not include patients from walk-in or hospital ambulances. So we further conducted researches and find that the total number of patients will be 4 times of the patients arrived from 911. So now here we multiply ratio by 4. In addition, since the arrival data doesn't follow a Poisson distribution, we will use the universal spline curve across 24-hour periods. And the range of patient arrival is between 6 to 18. And based on the publications and the hospital data, for each shift in NYP World Cornell, the intake nurse is 2, the doctors is 3, and the beds is 15. And for the service time, we also use the industry average and also based on our personal experiences. So the intake nurse is around 15 minutes. For doctor's visits, it's 20 minutes, and the bed turnaround time is 48 minutes. And we assume the service time follows exponential distribution. In order to test our model validity, we use 4 methods, the real world data. So we use EMS incident data. We also did researches using the publications by the hospitals. We conducted the statistic tests such as chi-square test and K-test. We also use the face validity where we ask expert doctors to review the overall process, and also we incorporate our personal experiences. And finally, we did a sensitivity analysis where we slightly change the input data and to observe if there is a large change in the output. So once we validate the model, we conducted 100 simulations of the model using the Monte Carlo simulation. So now, as we can see from the graph here, the average waiting time for the regular patient is over 200 minutes, and the total discharge or further treatment for regular patients is over 300 minutes, which is really high if you think about it. If you go to an emergency department, which means you think you are seriously ill. And if it takes over 3 hours before you can see a doctor, you might be stressful. So how can NYP World Cornell to reduce the total waiting time? We actually did a sensitivity analysis here, and then we graphed with a heat map. So the range for where we can change the number of nurses and the number of doctors for each shift to reduce the waiting time. So the range of the intake nurse is from 1 to 4, and the doctors are from 2 to 5. The composite score is calculated as the sum of total waiting score and the staff utilization score. A lower score indicated a more favorable composite. Here we can see as the bed number increases, the composite score actually increases, which meaning the utilization for beds is pretty low. So increasing the number of beds doesn't really improve the composite score. So here the optimal composite configuration we choose is with 10 beds, 3 intake nurse, and 4 doctors. And using this composite, the average waiting time for regular patients can be reduced to around 135 minutes. And the nurse utilization and the doctor utilization will still above 74%. But if you think that 5 minutes is still high, right? It's still over 2 hours before you can see the actual doctor. So it's really a hospital's decision to see if they can add more staff to reduce the total waiting time and if it is worthwhile for the hospital. So we actually increase the range for the doctors and the nurses and to see if that's possible. Here as we can see, just by adding 1 additional patient for each shift, the total waiting time for for regular patients reduced significantly from around 2 hours to just slightly over 1 hour. So it is really a hospital's decision to see if they want to add 1 doctor during peak hours. And now this is our optimized strategy where to minimize average waiting time for regular patients while maintaining a reasonable staff utilization during weekdays. So for the staff level, it's 3 nurses and 4 doctors. Then the average waiting time for regular patients will reduce by 33% while maintaining a staff utilization over 34%. And to conclude our presentation, we know emergency department service affect everyone, and finding the optimal staff mix can significantly improve the patient flow while reducing anxiety and stress during care. And for our model, we can do further adjustment, such as breaking down patients into various levels. Instead of just 1 to 2 and 3 to 8, we can further divide the patients into 3 or 4 categories. Incorporate actual service times and patient arrival data, because we do not have the inside data of the hospital. So if the hospital staff, they want to use our model, they can incorporate the actual service time and actual patient arrival to get a more accurate simulation model and output. And finally, our model can also be applied to other hospitals in NYC, as they can use different zone codes for patient arrivals. Now we are using zone codes for M7 under the EMS incident data. If the other hospital want to see what happens to their hospital, they can just change to a zone code that applies to that hospital. And also they can consider facts such as service time, staffing levels, and infrastructures and charge systems according to their hospital's policies or actual conditions. And that's all for our presentation. We're open for any questions. Thank you.
Thank you.
Thank you.
Very, very nice job, especially, I have to say, especially Judy, Calvin. I know you participated in it too. And very nice work. It's a good topic. Questions or comments, anyone? Seiki?
Yeah, I think like in comparison for my presentation, there's more like data driven. I really think that it is really good like in terms of having different datas and like graphs to compare, and it was really clear. I was just like I was just curious, is it in like real in the industry for emergency room? Is it like they have really just 2 intake nurses on averages? Because I'm not sure, because this is not the industry that I'm in. So I was really shocked because like 2 nurses is like really I thought it would be a little more for nurses part. It was really shocking for this part. I just curious about it.
Yes, we actually conduct industry researches, and we do find different hospitals might have different numbers, but the average intern nurse is 2 to 3. And then for my personal experience with that hospital, we went there during around 9 p.m. There's only 1 intake nurse, but I only went to the pediatric department, so they might have another intake nurse for the adult departments. So we figured 2 might be feasible for that hospital. Yeah.
I think in 2021, there were still COVID admissions. right? Because I remember
Um,
you said
yes,
2021 to
2021 to
2023.
2023. Yes.
Yeah. I guess it was way reduced, especially in the summer. But in the, uh, I don't know. I know that it was reduced, but there were some. So you didn't
Mhm.
avoid it completely, but I'm sure it didn't change the results. Preston?
Yes, just because this is my area of expertise, a couple of questions. Um, one, with thank you for breaking down how you filtered out some of the data of ambulance rides. I was just wondering, did you also filter out ambulance rides that were going to a psychiatric ER versus a medical ER?
Uh, because our data set didn't include that, so
Yeah, so
we don't have that
the
filter.
s- the source for our data set, we just pull out the data from the New York State Open Data.gov with the EMS. So from that data set, we don't actually have the the two atom you've mentioned.
Okay,
So in
interesting.
other words, it would have been combined together. They didn't distinguish it.
Yeah.
Uh, okay.
Interesting. Because that could also, because if you have this division there, I mean, you wouldn't know this because healthcare is not necessarily your background, but that would be a division in your line on the Cloudus, basically for one route going to medical care and one route going to psychiatric care because they are two separate wings. They have different doctors, nurses, beds, all of that. If you ever wanted to look into this further. And two, I was wondering if you saw any data on patients after they had arrived at the hospital balking due to their insurance not being accepted. Little factoid here for you. About 50% of all ambulance rides in the US are not covered by patient's insurance, meaning the patient has insurance, but their insurance won't pay for that particular ambulance. They would have paid for a different ambulance, just not the one that the person happens to get. So I was just wondering if you
Horrible.
had any data on patients balking once they got to the hospital, realized their insurance was not going to cover this visit.
No, because that data set didn't include the data. It only has like which zone area for the hospital, and then it has the arrival time, and then the severe level for the patients. That's pretty
And that
much.
that's a fault of the data set. That's not your fault. I was just curious.
Yeah, I didn't include it.
No, no worries. Thank you.
Right. I mean, we should put a data from the government website. So like whatever in there, we just use them.
Exactly. Good. It's good that they have this data. Very nice. Seiki, you have something to add?
Yeah, I was just curious, like, would it be able to just add some like the features that Prash didn't say about like maybe bulking? I think it's interesting to know, but I'm just like because I assume like because if there's not data, but I think it would be like really cool to like add some features on it to just play around on Cloudus. I don't know, I just like to play around with Cloudus. I think that's an amazing tool.
The master of the gigantic Cloudus model speaks. Very interesting. Anyone else have a comment on this term project? Okay. So then thank you very much. Great job.
All
Thank
right.
you.
Thank
Let
you, everybody.
me, I'm going to stop the recording and then start a new one. How's that? Try it again.